So welcome everybody. My name is Nicole Albanese Bell. This is my husband, Cedric Bell. We are the founders of the Hope and Healing Foundation for Suicide Prevention and Mental Health Wellness. Today we are doing a presentation and Cedric Bell is going to introduce our presenter and the topic.
Thank you, Nicole. Tonight, folks, we have a special guest speaker, Ms. Genia Bonchuk. She is a licensed mental health counselor who specializes in trauma therapy to children and adolescents. She received her BA Masters of Arts in Education from the National Pedagogical University. I'm butchering that, from the Ukraine. Ms. Bonchuk went on to receive her second master's degree at Nova Southeastern University of Florida. And for the past 6 years, Genia has been conducting trauma therapy within several community-based agencies, along with working with the Florida school systems, conducting on-site intensive therapy for children and families. Ms. Bonchuk is trained in multiple trauma modalities, such as EMDR, RTEP, GTEP, evidence-based emotional freedom technique, and that is trauma-focused CBT, along with behavioral therapy. Ms. Bonchuk has been licensed since 2019, and we welcome her tonight doing a presentation on trauma, signs, and symptoms in children. We welcome Ms. Genia Bonchuk.
Thank you so much, Cedric. Thank you. Thank you, Nicole. Happy to be here. Trauma in children is my passion, and I've witnessed a lot of it, treated a lot of it, like you said, the past 6 years. So everything that I'm going to be talking about is what I witnessed working with families and working in elementary and middle schools here in Florida. And some of the schools were Title I schools. And so just to give you a little side note, Title I schools tend to have more traumatized children because low socioeconomic status goes along the lines with trauma. So I am going to start screen sharing and I'm going to go into my slides. Okay, here we are. All right, so today we are going to talk about trauma signs and symptoms in children. And like Mr. Cedric said, I'm licensed mental health counselor here in Florida. So we will talk about big traumas and small traumas, what that is, and so how exactly it affects a child's beliefs about themselves and about life and about other people as well, and also effects of trauma, physical, mental, emotional, and behavioral symptoms to look out for. And also we will talk what triggers are, because that children get triggered all the time, and so we need to know what that looks like. All right, so what is trauma? Psychological trauma is a type of damage to the psyche and to the mind that occurs as a result of distress and event. And we will go specifically into what the distress and event can be, but basically, to give you a heads up, it can be anything from a car accident and a sexual abuse incident to being bullied or to being publicly humiliated. So the range is really huge. And the thing to know is that traumatic situation is a subjective experience. So what we might think of as a traumatic situation might not be all that traumatizing to the child, and vice versa. What we think is not traumatic at all is a big deal to them. So it's subjective perception of the event that really defines whether it was traumatic or not our thoughts about it. So trauma is often the result of overwhelming amount of stress that exceeds child's ability to cope, and they are not able to make sense of it. And when they do make sense of it, when their brain interprets the situation, the interpretation is negative. So many times when the child gets molested, the interpretation, the negative one, is, oh, it was my fault. I was the reason why it happened to me. Or they often mistakenly think bad things happen to bad people. And so that becomes their new belief. So now that triggers another negative belief. since I'm a bad child, I'm not worthy of being treated nicely, of good things. I'm not worthy of kindness, etc., etc. That's why trauma is so important to be aware of and to catch early and to heal it, especially in children. So trauma violates a child's sense of safety, self-image, and self-esteem, which is what I just mentioned, and it leads to the psychological feelings of shame. Like I said, this was my fault, or I'm a bad child. That's what feeling of shame is. Goes along with that belief, that cognition, feelings of guilt also. So the children, when something bad happens to them, they lose sense of control over their life, and they lose trust in sometimes in themselves and other people, or just life in general. So then we want to talk about small traumas, but like I said earlier, what we think is a small trauma can be a big one for child and vice versa. So these are just some examples, but the list goes on. So public embarrassment, humiliation, like in the classroom or in front of the family members, in front of their friends and stuff like that. So like some sort of a negative feedback, or especially name calling and stuff like that. Unfortunately, some teachers do that, some family members do that. They think it's effective, which it is effective from the standpoint that once the child starts to experience guilt and shame, they are going to be much quieter. So it's effective in the classroom, but it's really traumatizing and damaging to a child's psyche. So any kind of conflicts with friends, with best friend, with a group of friends, when important adults not keeping their promises, children get really upset about it, and it can reach the level of distress that can be traumatic. And when child is not being believed, that can also be a trigger for a traumatized child. And when they're being called names, so when their pets are dying or undergoing any kind of significant surgery procedures. Okay, so now we are talking about bigger traumatic events. So that can be domestic violence, whether they're a part of it or they're witnessing it. Sometimes parental divorce, when it's nasty divorce, it's understood that it's going to be traumatic. But sometimes even just divorce itself, child's world gets shattered, the family gets split up, and life as they know it ends. So even if divorce is kind of like peaceful, it still can be a traumatic experience. So obviously tragic and sudden loss of a parent or a caregiver, substance abuse in the family. Some of these things are understood and other ones not so much. So like scary medical procedures, these get very often overlooked because we just think it's understood that, you're going to get better and all of that. And we completely overlook the fact that the child is going to be in unknown environment surrounded by people they don't know. It's scary, and they're not going to be there next to their loved ones for a little while. So it's really important to address any kind of medical procedures. So foster care, obviously natural disasters, and poverty, like I mentioned in the beginning, low social economic status, it's poverty, homelessness, and overcrowding of the house. There are some kids where there are 10 people live in a 2-3 bedroom house. They don't have their own space. They don't have that one-on-one attention and love from adults, and so that can be traumatic. Usually, it's a lack of resources like food or clothing, school supplies. All of that creates those negative beliefs many times. So then difficult life transitions, maybe moving from one state to another and leaving all of their friends behind and maybe some of their relatives and, the school that they liked and stuff like that. Physical and medical limitations and conditions. So kids who have things like asthma, or if they have ADHD, or if they have any kind of a disability, the reason why it can be traumatic is because they might think I am less than everybody else. I'm not as good, I'm not as valuable, I'm not as successful, etc., etc. And so those negative beliefs and cognitions, that's what defines trauma essentially in this situation. Being attacked by a dog or exposure to inappropriate content in person or on the screen. So we are talking about sexual content, violence, and things along those nature. So now, how traumatic experience affect child's perception of self and life? Usually, if this family is highly functioning, if everything goes well, beliefs before trauma is I am lovable, I'm worthy, I am good, I am safe, people are kind of trustworthy, I am respected, and I have choices. So all of these are beliefs that we want to have about life and we want kids to have about life. So when traumatic event happens, when their world falls apart by whatever situation that causes that, then the belief after trauma become I'm unlovable, I'm not worthy of, I put ... I'm not worthy. That implies anything good, of love, of kindness, of success, of good things, of good experiences, etc. And so that's where self-sabotage and patterns of behavior come from, or they don't try to do better, whether it's school or just in daily life. I'm defective, I'm not good enough, some of those negative beliefs, I'm not safe, and I cannot defend myself, I'm helpless. And another one that I mentioned earlier, it's my fault. So now we are going to talk about physical symptoms. Kids will talk about headaches, stomach aches. You will see that physically they are tense and alert. They lose the ability to relax because another thing that happens, they start to believe it's not safe to feel safe. It's not safe to relax because I have to be alert to defend myself if I encounter the dangerous situation again. So wetting and soiling problems at night or at school, that could be another physical symptom. Hypervigilance, constantly expecting something bad to happen, constantly being alert. They're easily startled by any kind of loud noises or anything that happens suddenly. Does not even need to be loud, to be honest with you. So they just jump and they, what we would say, they would overreact. So definitely difficulty with sleep. That's one of the most common symptoms, difficulty falling asleep, staying asleep, or waking up early. Also nightmares go into that category. They're anxious and restless. It looks like ADHD, and that's why ADHD is the most misdiagnosed disorder in kids right now. In reality, probably half of those kids are traumatized kids. It's trauma that has not been healed. So panic attacks are mostly prevalent for a little bit older children. We're talking about middle and high school, not so much elementary school, but we're talking about kids overall. So I put it in there. Loss of appetite, self-mutilating behaviors. Self-mutilating behaviors, that means doing any damage to the body, cutting, picking skin. We will go into that a little bit later. So that's what it is. And physical aggression towards others, towards property and things. Okay, so now mental effects of trauma. Hyperactivity and difficulty concentrating. Like I said, confused with ADHD symptoms. Poor decreased memory abilities. So when the child is concerned about their safety, their ability to learn is going to be diminished. They are not going to be able to concentrate and focus and to perform academically until that sense of safety is restored. And that's what we do in therapy, one of the things. So social and academic functioning as a result is going to decline. So if all of a sudden A and B student starts performing on the C and D level, you have to look and see what's going on there. Suicidal, homicidal thoughts and statements. I want to die, I want to kill myself, I don't want to live, that kind of stuff. selective mutism that happens sometimes. So selective mutism is the child stops talking. They might talk in some situations to some adults, maybe to their parents a little bit, or to a trusted adult. Sometimes they stop talking at all. And so that's really one of those pointers that there was a traumatic episode. Flashbacks. Flashbacks is involuntary memory that pops up in their head in the middle of the day, at night, when they don't even try to think about it, and the memory is there of the traumatic situation. And many kids might stutter. Okay, so suicidal and homicidal statements. I gave examples of it, what that sounds like. It's pretty self-explanatory, but I wanted to talk about when we are doing assessments, and anybody who wants to do any kind of assessment, this is what you want to ask for. If there is a statement, ask when they first started having the thoughts. That's what onset means. Frequency, how often during the week, how often during the day, per month, etc. Duration. Is it 5 minutes? Is it just a fleeting thought, or do they sit there and they ruminate for an hour? I want to die, I don't want to be here. So intensity, is it kind of like it would be kind of nice not to wake up tomorrow, or is it like, oh my god, I want to do something to myself and I'm actually going to figure out how I'm going to do it, which is what planning is, right? Sometimes I like, did you think about it, how you would do it? And they're like, no. And sometimes I say, how would you do it? And they actually have a very specific answer. And you might be surprised, the youngest ones, they have those answers like clear as day. And so intent is the good scale to measure intent is you would ask a child from 0 to 10, how strongly do they feel about actually acting on their plan. And they will say, oh, I'm definitely doing it. That's a 9 or a 10. And they say, oh, 1 or 2. So that also gives you an idea whether you always should take it seriously, but that's the difference between having to take the child to a psychiatric unit in the hospital, which is called Baker Act, or whether you can just kind of enroll them in therapy and address it there. So attempts, some kids might actually attempt to suffocate themselves, to swallow pills and overdose on pills, or to cut their wrists. So you want to look into that. Access, do they have access to those pills? Do they have access to sharp objects? Do they have access to anything else that they're talking about, how they're going to do it? So risk factors and protective factors. Risk factors is, let me just stop the share for a second so that you can see my face. So when we talk about risk factors, it's anything that might throw the child over the edge and actually make them act on their plan, plan to commit suicide. So let's say the situation was already bad, they were a victim of any kind of violent situation, and then their pet dies. That's what I mean by risk factor. Or their relative is not doing well, and then something happens to the relative, or their best friend just moves to another state. That's the kind of risk factor that you want to look for, because in that case, you want to pay much closer attention to the situation. And protective factors are the ones that might prevent child from committing suicide and might give them the reason to live. So people that they love, activities that they engage in, if it's soccer, if it's their chess club, if it's any kind of like a band, musical band, their favorite teacher, they love it at school, and they love spending time on the weekends with their cousins or whatever. So all of those are protective factors, and you want to have as many as possible of those, because that's a difference between life and death, basically. So children who are from like dysfunctional families and environments, they have many more risk factors, and poverty is obviously one of them, than kids who have good life, up until the traumatic incident, and then they are going to recover much faster. So that's why when I said that Title I schools have many more traumatized kids, that kind of goes into that. Okay, so that was the risk and protective factors. Now we're going to go into the next slide, which is let's see. We got stuck a little bit here. Okay, self-mutilating behaviors. So let's talk about what those are. It's any kind of cutting of the skin. It can be the most common one is on the wrists, on the side where the vein is. However, you can see it on the other side of the hand as well, kind of like towards the elbow. So you want to see, especially in teenage girls, although it happens with boys too, you want to see if it's in Florida summer and it's June, July, and it's super hot outside and they're wearing long sleeve hoodies and shorts, what's going on? You want to pull up that sleeve and see what's going on. Many times that's the reason why they're wearing long sleeve clothes, because they're covering those cutting marks. Pinching the skin to the point where it's obsessive and it causes actual marks and something that's abnormal. Thicken the skin until it bleeds with hands or objects. So pulling out hair, pulling out eyelashes and eyebrows, that would be self-mutilating behavior. That is a sign of distress, sign of trauma. Hitting knuckles on the hard surfaces, that's common for boys because they tend to express their distress through aggression, and cutting is more prevalent for girls because girls impose pain on themselves in that way more often. And so hitting the head on the wall, on the desk, these kind of behaviors are more common for elementary age school kids. Okay, so emotional consequences of trauma. You're going to see moderate and severe emotional dysregulation. Even the mildest comment might set them off into either a crying spree or aggressive episode where they're just losing their mind and they're cursing and yelling and trying to hit and stuff. So that's what severe emotional dysregulation is. Sorry. Predominantly depressed, irritable, angry mood. Like I said, boys get angry, girls get depressed. Child is shutting down, withdrawing, multiple. We are not talking about one-time episode. We are talking about consistent behavior during the day, many days in a row. That's how we diagnose, and that's what's clinically significant behavior. Okay, so you can see noticeably low self-esteem. The signs of that would be the kids would try to cover up their bodies, try to make them themselves invisible. So that would be hoodies, putting the hoodie on and not taking it off, or not standing up for themselves and taking any kind of picking or bullying from their classmates, their friends, giving away things to be liked, to be accepted by other people and peers. And many kids do that anyways, but we are talking about level that exceeds the normal behavior. So another sign would be of trauma would be drastic negative change in mood compared to the baseline. Baseline is what's normal for that child before the traumatic episode. Inability to emotionally connect with others, which is social isolation, and very low distress tolerance. So social isolation is not wanting to make friends. All right, so behavioral issues that you will see, and those are the easiest ones to identify that something happened. They can be aggressive, and they can start bullying other children, impose that pain onto other kids. Defiant, they might be argumentative, hyperactive. Hyperactivity is one of the major symptoms. So they look fidgeting, like they cannot still sit still. Even if you ask them, they are just not able to. Sometimes they can be super low energy level, which is the opposite. So the nervous system is shutting down and they look lethargic, falling asleep often, not being able to maintain eye contact, that kind of stuff. And so then younger children who were exposed to inappropriate sexual context, they will be talking about that and replicated it in their conversations and talking to their friends and stuff like that. So before you go ahead and start punishing them, look into that and find out what actually happened, where all of this is coming from. Eating disorders, this is more common for kids 8, 9, 10 years and older. The age of eating disorders in girls has been much younger now, the onset, compared to 10, 20, 30 years ago. And so self-mutilating behaviors, we talked about that. All of these things, and especially multiple symptoms, you have to assess for trauma. Even if you think nothing traumatic happened, like there is a reason why the child is behaving this way. So trigger is re-experiencing the emotions created by trauma. So basically, they re-experience it mentally and physically. They physically means they're going to have the same sensations in the body as when the traumatic incident happened, and they're going to have the pictures in their mind that come up and emotions. So that's what the trigger. It's the same as they feel as though the traumatic experience is happening right this minute, even though nothing actually, from your standpoint, nothing actually is happening that's bad. So anything can trigger trauma. It can be familiar sound, smell. You can touch the child in a way that will set them off. It can be seemingly innocent event. They might see something, and sometimes there is no visual trigger at all. It's just they might think about it and then start crying hysterically in the classroom. So let's see. Yeah, so what happens when they experience a trigger, they will have either severe outbursts, it can be aggression, or a meltdown. They will be crying uncontrollably, and it will be difficult to stop them and to console them. And another thing, important thing to know, and this is what teachers are unaware of, and they get mad and frustrated with kids. Kid is not aware what's happening. They are not aware that they got triggered and their trauma got triggered. So it's nervous systems, the normal functioning of the nervous system has been basically violated in a sense, and the child is just the witness of that. And they are not necessarily a willing participant, and they are certainly not initiating any of that reaction and emotion. All right, this is my last slide for today. What we do to help in therapy. So number one thing that we do, we want to restore that peace and sense of safety. We are doing techniques that help kids feel safe in their body again. We are helping them to relax and to give themselves permission to relax and to feel safe again. And this is step number one, and that's a big one. We give them corrective experience. So if they were abused, if they were mistreated, if they were neglected, in therapy session, we validate them with positive feedback, with compliments. We empathize with them. We show them kindness, respect. We support them, and we create a safety environment with our body language, with our words, and what we do. And so with kids, especially with younger ones, a lot of it gets accomplished by play. playing games. So then we instill in the positive beliefs. What I said earlier about how initially positive belief the child has about themselves and about life and other people, we want to get those beliefs back. We want the child to believe again, you matter, you are safe here, you are lovable, you are worthy of love and kindness, and you can, it was not your fault, and etc. So we provide child with those experiences so that they can get back to those positive beliefs again. So advanced trauma treatment techniques, emotional, EMDR, eye movement desensitization and reprocessing, evidence-based emotional freedom technique, trauma-focused CBT, and RTAP, GTAP. That's for recent traumatic incident that one-on-one and in group setting, we do that. So that's my presentation for today.
Oh, all right. Thank you very much, Genia. That was very, very informational. Got a lot out of it.
Yeah.
And I just want to ask you a question or two, if I may. And that's particularly relating to that last slide. I seen that EMDR, which is kind of like the new thing now, okay, that all the clinicians are utilizing. What is your take on the positive outcomes of EMDR, utilizing that particularly more over these other techniques? Do you find it more beneficial, and why?
Yes. First of all, it is super beneficial. And second of all, the reason why is because it's scientific. It's researched, and it's the whole system. It's a protocol, it's 8 steps, and it's very clearly outlined every single step. And so you know exactly what you're doing. You are healing the psyche on a very deep level. You are getting in parts of brain where the memories are stored. You are disassembling the negative memories, and you are instilling the positive experiences and the positive beliefs for a child on a deep level, on a level of thought, and on a level of physical sensation, and on a level of belief. So EMDR is magic. If you don't know how it works and you get experience of it, it's like, oh my God, it's how did it happen? So it's effective and it's sustainable. It's not like you get you don't get to process it once and then the traumatic memory comes back. Once it's processed, it's done, it's healed, and the child can move on. So I love it.
Powerful.
That's powerful. That's really powerful. Now, you mentioned play therapy. I'm more familiar with play therapists, okay, and how they utilize that interaction to decrease trauma within kids. How is that utilized along with any other intervention, okay, as a combination, or you just do the play therapy itself without utilizing CBT? I'm thinking that's kind of a connection there.
Play therapy is actually part of EMDR when we are working with kids, because we cannot, many times we cannot play and be stressed out at the same time. So when we're talking to a child, once we are able to fully engage them in this present moment, here is my office, it's a safe space, the music is playing in the background, all of these fuzzy toys and everything looks really nice and colorful on the walls. Once the child is in the present moment and they are playing, they are finally able to tap into a sense of safety, into a sense of calm, joy, peace, relaxation, and happiness. And so then, but that's like one part. The next part, and this is what why EMDR is so deep and I like it so much, you use bilateral stimulation, which it can be one of few things. So this would be bilateral stimulation. You are stimulating both parts of your brain in this particular way, or it can be taken, I call it the magic wand. I have this fluffy, colorful pen, and then I tap on child's hands when they are on the desk. If they are not able to do this, they are just too anxious. Or when I say, okay, watch my fingers with your eyes, that would also stimulate left and right part of the brain. And when we do that, and then we say, okay, so now see how you feel, pay attention to those feelings. Where are they? Oh, they're in my heart. Okay, what does it feel like? Oh, it feels like butterflies in my stomach. It feels so good. Okay, all right. So now, are you relaxed? Are you happy? Yes, I am. And what are you thinking? Are you safe? Yes. All right. And so now we call it tapping it in. And we just, when we do this, that experience gets internalized in the body, in the mind. And so then the child gets to hold on to it. And then I say, okay, when you're in the classroom, when you're at home, if you're stressed out, just say the code word. I have them come up with a word for that particular experience. Oh, wonderful time with Miss Bonchuk, for example, right? And then, okay, do this. And when they do that, all of those feelings come up. So it's not a thought in the head, it's way deeper and it's way more effective. So that's where the place of play therapy aspect of it in the EMDR working with kids.
I have to say, that was the best explanation of
was.
EMDR
I have gotten.
I have ever heard. Okay, and truthfully, I mean, being so new, I want to say so new, or maybe I'm so old, but being so new, I really couldn't get it. And I said, you know what? You know, I'm very skeptical. Okay, does this work? Does that intervention work? Whatever have you. But I've heard a lot about it. And up until now, Genia, I was very confused about the whole processing in it. And I appreciate you explaining it the way you did.
Yeah.
Yes, well, thank you for saying that. That's just how we instill the sense of safety, peace, relaxation, and happiness in the child. But then we also use bilateral stimulation. It can be this or any of those other methods that I showed to dismantle the traumatic memory. So once the child, the first step is to teach them to regulate their emotions and to create trauma makes their ability to tolerate stress this small. Anything can set them off, anything big or especially small. So initially we teach them to not, to be able to tolerate maybe this much stress. And once we lay that foundation, and once they're able to regulate between stressful memory and the ability to snap out of it and to contain that emotion, then when they are ready, we're moving into another phase of EMDR where I say, okay, now think about the traumatic memory, and we are going to process this and what's coming up for you. And so that's how we call it the distress tolerance window. There is a stop sign. If it gets too much, you tell me like this. You say, okay, stop. Okay, already. And so this method processes the body, and the mind has this natural ability to heal itself. And that's what gets engaged, pulled into the process when we do bilateral stimulation. So it brings the memory and it pushes out the negative belief, the negative cognition. And then once that gets neutralized from -10 in terms of like stress level, well, we use SAD scale from 0 to 10, how stressful it is. So that will be like from the stress level number 8, 9, 10. We neutralize that stress level to 2, 1, or a 0. And then we use the same bilateral stimulation to instill the positive belief. I am good, I am lovable, I am safe. And then if initially, how strongly do you believe that you are good and you are safe? It's two separate things. So they say from 1 to 7, they say 1. So we do bilateral stimulation, and that 1 grows to 2, 3, 4, and until it's a 7, we just keep going until it's 6 or a 7. And then it's like, it's deep, it's meaningful, and it stays with them. And that's what bilateral stimulation does.
I think that's very useful, and it's going to be very useful for people who are able to hear this, especially people who are looking for it for their child, because it sounds like it's an intimate moment. So if somebody's looking for it for their child or for their loved one, this is something that they're able to understand it a little bit more for what's going to be happening with them. But on that note, I have a question for you. What is it something that people can do who are not maybe at our levels of clinicians or somebody who's been trained and stuff to be able to help their loved ones, or if they're a teacher or any of that, if they're working with children, to be able to help them in those moments? What is something that you would suggest for them to be able to help them, or to recognize whatever it is, to be able to get them to a place of help?
Yeah. That's a really good question. I thank you for that, Nicole. So thing number one to know is I run into situations where teachers know that the child experienced their caregiver passing out on the floor and being taken away to ambulance, for instance, right? Or they were in a car accident, and then the mom stayed at the scene and the child was sent to school on that exact same morning. Teachers know that these things happening, but then because they don't see any signs, anything different about the child in the classroom, they think, oh, he's okay, he's fine. Some things, I know I said that trauma is subjective experience. Some things are traumatic, period, the end, that they need to be looked into that. So number one thing to know, if there was a traumatic experience like that, even if the child does not show any of the symptoms that I was talking about that you can see, it's the child still needs to be assessed for trauma by a specialist. And the person, even though they don't know much about therapy, they can still ask those questions. Are you okay? Are you able to sleep? Do you see any nightmares? Is it difficult for you to concentrate in the classroom? And if they are tense, all of those are the signs. So that's thing number one. Thing number two is to know that the child, anytime you see the child misbehaving, it means that they either don't have a skill because the parenting at home is not that great, or maybe something bad did happen to them. So number one thing to deal with a child is to be assertive, to provide negative consequence, but to not be mean to them, to not take any of this personally, and not to fly off the handle or have this intense anger inside. Oh my God, he's disrespecting me. Oh my God, he's attacking me and stuff. And then it becomes personal. So never take that personally. Naturally, kids are very kind. They search for love, and they are pleasers. So if they're aggressive, that's a sign that something's not going well at home or outside of home. So not to be nasty to the child, condescending, and not to make things worse for them in terms of mental health. And another thing is, if you are a parent, if you're a caregiver, if you're just a caring adult in a traumatized child's life, what would be super helpful is to provide experiences when child feels safe, loved, appreciated, cherished, respected, and all of that you would do through quality activities, through one-on-one time, and most importantly, through play and games. Let them win at Uno, let them win at Sorry. When they win, cheer them on. Oh my God, give them a lot of positive feedback, compliments. I believe in you. You're so kind. You're so nice. You're so smart, etc., etc. And you're so strong. And those are the things that people can do. But that's besides therapy.
Yes.
All right.
Well, I think that that's it sounds like it could be common sense in a sense, but it's not. And it's really not. And I think it's very useful of what you just stated. And I think that that's something for people to really understand is that kids can be kind and to really just understand that if they're not, there's something going on, and to show love, to pay attention, and to have quality time. I think that that's a very good kind of synopsis of it all, of what to do.
These are essentials for the mental and emotional well-being of any child to begin with, but especially for a traumatized child.
All right. Last question. I want to ask you about, you mentioned the misdiagnoses of ADHD comparing to
Yes.
PTSD, we would say. Okay. How has that been affecting you as far as diagnosing? I mean, what do you see? Why they're being misdiagnosed? Why is the ADHD being misdiagnosed, and they should be more diagnosed towards having a trauma in itself? They do have two similar behavior patterns. So I'm trying to distinguish, what do you think is the major difference people should look out for, okay, when they're trying to diagnose the ADHD towards the trauma diagnoses?
Okay, so how to distinguish between the two? Number one, in trauma diagnosis, when it's a consequence, when this behavior, when this restlessness is a symptom of trauma, there is a traumatic experience. So you have to look for it. You have to ask what happened. And, sometimes those questions can be those experiences can be overlooked. Oh, parents arguing at home. Well, wait a second. If they are arguing to the point where mom comes home from work or dad comes home from work and they're drinking and one is throwing the other one out of the house and there is screaming and yelling and the kid is crying in their bed, in their bedroom, that's not just arguing, that's the child is getting traumatized. So you cannot let your own biases to overlook those kinds of things. Or cat is sick and cat is dying, or guinea pig. Oh, what's guinea pig? It's okay, it's not traumatic. Well, it is for that child. So to distinguish between ADHD and trauma, there is a traumatic experience, and because it's a child, their perception of the world is so exasperated. Everything is a big deal. So that's why the guinea pig is a big deal, you know?
Yeah.
And you have to find those things. And another thing is we tend to fix everything with the pill. ADHD is just so easy. You just give them a pill and then the restlessness stops. The mom does not have doesn't have to spend money taking them to therapy, driving them, paying, dealing with insurance and all of that. The doctor is like, okay, here, and the problem goes away. The teacher is happy, does not take any time. It's just like instant, and we're good to go. And in fact, many times, even when professionals or caregivers know that the child was traumatized, they still prefer to give them a pill and not to deal with the symptoms. So there is the convenience factor in this too, and that's another reason why it gets misdiagnosed. And the third factor, I would say, just low awareness. People just don't understand trauma. They don't understand how it affects the brain, how it affects the body. And even medical professionals, they were taught everything about the physiology, the physical aspect of the body, but maybe not so much of the mental and emotional functioning. And so then they are lacking knowledge to connect the dots.
All right. Well,
Good.
thank you very much. And I don't know if Michaela, do you have any further questions before we close?
No, I just wanted to say how intelligent, well-versed, and so you can tell how passionate you are. And this is something that hits really home for me. And I wish you were around when I was a kid. I'm sorry to get emotional, but like everything you explained and like going through, I wish I had someone there for me when I was a child like you. So I think what you're doing is so important, and just keep on fighting the fight. So thank you.
Thank you, Michaela.
Thank you, Michaela. Thank you very much. And yes, it was very informative with the information that we have on this video. I think that a lot of not just professionals can utilize, but also the general public. And Genia, you explained everything in so much detail that, you know, if you wasn't a professional, you really can get what you're saying of how to deal with it and the signs and symptoms that go along with it. So we thank you again for joining us.
Thank you for the opportunity.
Ladies and gentlemen, we are the Hope and Healing Foundation for Suicide Prevention and Mental Health Wellness. We thank our special guest speaker again, Ms. Genia Bonchuk, okay, licensed mental health clinician in the state of Florida. And we thank you again, Michaela, our secretary for the foundation, for attending and to helping us out with everything. We will be seeing everybody next week, same time.
Next month.
Next month.
Next week. He's jumping ahead.
Oh, yeah. Next month, same time, same place. We thank you all for joining us. And once again, have a nice night.
Thank you.
Thank you.
Thank you, everyone.
All
Thank you.
right.